Privatization and the for-profit nature of medicine is what's destroying our healthcare system.
Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision and the culture of healthcare systems. Hello, everyone. Welcome to episode number 42 of the License to Lead podcast. This is Patty Fay. My guest today is Dr. Susan Rogers, the president of PNHP, which stands for Physicians for a National Health Program. PNHP is a national organization that has over 24,000 doctors, and they advocate for single-payer healthcare in the U.S. Dr. Rogers is an internist, a former hospitalist, and former director of medical student programs for the Department of Medicine with the Cook County Hospital System in Chicago. Recently, Dr. Rogers has been on Capitol Hill in Washington, D.C., battling efforts to completely privatize Medicare. And she's had some successes, which I'll ask her about. Two very good adjuncts to this conversation are License to Lead episode number 34 with Dr. Roger Fowler, who takes my hand and leads me through the alphabet soup of government programs and all things Medicare. And the newsletter accompanying that episode has a glossary of government program acronyms and much, much more, all of which you can find by going to the podcast page at fayconsulting.com. I asked Dr. Rogers to come onto the podcast today so we can find out more about her and her leadership journey, what she hopes to achieve with PNHP, and what we as physicians need to know about it, and her take on what underpins the gnarliest issues in healthcare in the U.S. Hello, Dr. Susan Rogers. Welcome to the podcast.
Well, thank you so much for inviting me to talk with you today.
Wonderful to have you here. I wonder if you would mind saying a little bit more about your current role, and you could correct anything that I said that was haywire in my introduction.
Sure. Currently, as president of Physicians for a National Health Program, I lead an organization of almost 25,000 physicians. And our mission is to advocate for a single payer program, or also we call it improved Medicare for all. And by single payer, we mean there is one payer, which would be the government, who would pay all medical providers. They would bill the government. The government would pay the providers. It's a very efficient system with an overhead of only 2%. So it doesn't waste money compared to our current system that has overheads of up to 15% going through insurance companies. So this way, everyone would be covered in this country. It's not attached to your job. It's not attached to anything other than you living here. And it covers all medically necessary services. We would expand on some things like include long-term care. We would cover dental. We would cover hearing. So there's a lot of things that currently are not covered by even insurance in our current system, whereas our universal care, single payer care would cover all of these medically necessary services that people need.
Awesome. I mean, that's just, I think, a great prelude to a little bit deeper dive that I'm going to pull you back into in a little bit. And before we go there, I would just like people who are listening to have a chance to get to know you a little bit better. And I wonder if you would mind telling us a little bit more about your background and a little bit about what led to your interest in medicine.
Well, I think my interest really got sparked when I was a freshman in high school and took biology. And my teacher at that point was the one who started, me on this road. And I just loved biology. And when I went to college, I was a biology major, not knowing for sure what I was going to do with that. But I knew that was what I was interested in. And eventually I ended up going to 3 different colleges. But when I was at the last college, I got with a group of other students who were applying to medical school. And that's what kind of really made me take that step and say, yes, this is what I want to do. I wasn't sure if I wanted to be a doctor, if I wanted to be a nurse, if I wanted to be a teacher, but that's was what convinced me to be a physician, was being with a group of other students. So that was how I got into medicine. Essentially, the spark was there from high school, but it didn't grow all the way up until I was ready to finish college.
I'm going to take you on a tiny tangent, I suspect, but I'm fascinated by this biology teacher in high school and what a tremendous impact teachers can have on us, really sending us into an unexpected direction. And could you say a little bit more about him or her? And what do you remember when you think about, yeah, I started loving this biology?
She was, I could say her name. I don't know if I should or not.
Yeah.
Her name was Miss Fitz. She was just a phenomenal personality. She loved what she was teaching, and she loved teaching high school students, no matter how difficult we could be at times. And this was back in the late 60s, early 70s, when all students are distracted, high school students, but especially during that time. But she was very focused, and she made learning fun. And she was supportive of students, and she encouraged us. And that was really what prompted me to pursue that. And I ended up taking AP biology as a senior. And this was back in the day, there was no AP test, so you got no college credit for it. It was just, you took it to learn more. And she encouraged us to do that. And so there's no question that, where people end up is a reflection of who they interacted with on their journey. There's no question about that. It's interesting. I look back at people who come up to me and tell me I was the reason they did such and such, and I had no idea that I had that impact on anyone. When we do things because we like what we do, the impact is often infinite because you don't even know you're having that impact. It's not like you're telling someone something because you want them to know this. You're doing what you do, and it tends to work,
You're energized. You're energized by what you're doing. And I think that level of energy and exuberance is contagious.
Yeah. And the passion that you feel yourself with what you're doing is contagious to the people that, you're coming in contact with.
Yeah, I love that story. And your comment about people coming up to you and letting you know that you had an impact that you were oblivious to reminds me, okay, tangent number 2. I went to a high school reunion, multi-decades after graduation. And I had a friend come up and tell me that I sat her down. We were in her bedroom in high school, and I sat her down on her bed, the way she tells it. I don't remember this. And said, you can do whatever you want. You do not have to be a secretary, because her mother told her she had to learn to type because she was going to be a secretary. And she marched up to me at this high school reunion, got right in my face and said, this is what you said to me. She'd become the head nurse of a cardiology unit in the hospital. And she attributed her change in mindset about career possibilities to our high school conversation.
Wow.
That is my main memory of that high school reunion. I was so thrilled. I know that you went to what I've kind of thought of as the somewhat renowned Colorado College here in my neck of the woods in Colorado. What was that experience like for you?
That was a very interesting experience. Back when I applied to go to college, nobody went to look at schools. Nobody did college tours. It was just looking at some pictures or whatever it is that, you thought looked interesting and said, oh, I want to go there. And you really didn't look into the school that much. And I had never heard of Colorado College until a friend of mine that I had grown up with, who was a year ahead of me, was going there. And he described it as you took one class at a time, and you took a class for 3.5 weeks at a 4-day break, and you took 9 classes a year. And I said, wow, that sounds great. And the school was in the foothills of Pikes Peak. I had never been that far west. And I felt, well, if I don't go to Colorado now, I'll never get there. So to me, it was a no-brainer. This is where I want to go. And I got accepted. And so I went. And it was a very totally different environment than what I grew up in. It was a small, almost all white liberal arts college where most of the students were very wealthy. I don't mean middle class wealthy. They were very much upper class, where their idea of a summer job was taking care of their neighbor's horse. And so it was a totally different environment. Plus, I had grown up in one of the few integrated neighborhoods in Chicago. And I grew up with white friends, with Asian friends, with Black friends. And coming to this almost all white school was a totally new environment. And when I look back, it's just a reflection of how segregated this country is. We live in our own environments, and unless we purposely or accidentally end up in an environment different than what we know, we have no idea of how the rest of the world or the country even functions. And with the segregation in this country, this is why people have no idea how other people live or how other races, how other cultures, other ethnicities. They're not aware of the circumstances other than what they see on the media or what's presented to them, which often may be biased. So it was a very, like I said, a very different environment. And I did not like it. I did not feel welcome. I was the only Black biology major,
Really?
In all 4 years, even though there were, I think, 60, 70 other Black students. Now, this is only out of 3,000 students. There was very few. And I just did not feel welcomed, even though it was a very excellent school. And I just decided I don't want to stay here. After my second year, I did not go back. And I went to a HBCU. And I was going to just the opposite way. And I enjoyed it there. But there were some reasons at home. And I ended up staying at home the next year for my senior year and went to a commuter college and took night classes and worked my senior year. And that was where I met other students going into medicine. So that's how I got to where I was. And also knowing that this was during the civil rights movement that was going on. I mean, I finished 8th grade in 1967, and it was just 2 years before that when the Voting Rights Act. And, the whole idea that my parents grew up not being able to vote.
Shocking.
Totally shocking. I mean, I didn't even know that world existed. And it wasn't that I was aware of voting as a teenager anyway, but, you hear this on the news and stuff. And I knew about some issues going on in Chicago. And I decided when I wanted to go to medical school that I wanted to train at Cook County Hospital in Chicago. That was where the majority of Black patients were seen. I went to medical school knowing I was going to train at Cook County Hospital.
Really?
I knew that was where I was going to go because that was why I was going to medical school, to take care of the patients at Cook County Hospital. That was my mission.
You talked about being in a very integrated neighborhood and environment as you were growing up. And at what point did you realize that you wanted to make sure that you were going to be able to serve the African-American patients?
Well, growing up in Chicago was interesting. The Black Panther Party was quite vocal and well known in Chicago. Mm-hmm. And names like, the massacre of the leaders of the Black Panther Party by the racist police force here in Chicago with Hanrahan. That was front page news. So it was clear what was happening in Chicago. My mother took us on a march when Dr. King came to Chicago when I was only in 7th or 8th grade, that marched against the segregation and the issues with the public schools for Black students. So I became aware of this partially because of my parents. My father grew up in the South. My mother grew up in Chicago. And so I was aware of all of this. And Angela Davis was my role model. That I had a big fro and the wire rim glasses. And those were the role models that I grew up with. And I still had a focus on what I wanted to do, but this was always part of how I prioritized things. I wasn't just a person. I was a Black person in this country, the Black person in this city. Those were very influential on the decisions that I made. And that's why I grew up wanting to go to Cook County I didn't need to know what it was like inside. I knew what was there.
And did it pan out the way that you had hoped? Something was going on there because you spent your career at Cook County. So you were...
Well, not the entire career, because I did leave and I went to work for an HMO because that was at the time felt to be part of the solution to the rising costs and the issues with healthcare delivery. I left there after about 4 years when our medical group went bankrupt, and I became medical director of an FQHC, a federally qualified health center, which was in one of the poorest communities here in Chicago that serviced one of the largest and poorest public housing complexes in the city, Cabrini Green. I don't know if you've heard of that, but that was a huge public housing development that was very poor, had few resources. And this was where the community health clinic worked. And then when I left there, I went to work for the VA. So I was still always wanting to do something that had some public benefit. It wasn't just about for me. I always had to serve a purpose in what I was doing. I started missing county. I missed the camaraderie. I missed what I was doing, even though I loved the other places I was at. And so then I went back and I went and worked in one of the primary healthcare clinics and worked there for about almost 15 years and had some of the most wonderful patient experiences within that system there. And then I got more involved in teaching and became director of the medical student programs and the clerkship director for the students who came from Rush University, which was affiliated with the hospital, and became the director of that program when they did their required clerkship in internal medicine. So I got more into the academic side, but I was still taking care of the patients I wanted to take care of. And I thought it was important too that I taught students who were coming to see that who had never been anywhere near this community before.
Oh, say more about that.
I mean, most of the students at the school, as in all medical schools, were mostly white. They had coming to Chicago, working with Black patients who were poor was a totally different experience for them. And it was important that they understood why the people that we cared for were poor. It wasn't because they were lazy. It wasn't because they didn't care. And if they didn't take their medicine, it wasn't because they didn't want to. There were reasons for that. And it was important for me to teach them that and for them to see me as a role model. And it was important to the patients too. And so again, it was this focus on why I was doing things. It never left me. It never left me. And even now, I've retired from clinical medicine, but I've still got this focus, this sense of wanting to do the right thing, wanting to, with public health, with the issues that are facing people, I'm still involved in that. So that's sort of like been at my core. It's what I am.
You're very purpose driven. I mean, clearly it's been a sense of purpose driving your career.
I hope so. And I've loved it.
You loved it?
Yes. It was not doing something just for benefit. It was doing something that was part of me. It was, the passion has to come from inside.
Right.
I look at what I have done and it's been driven by the passion and for loving what I do.
I get to see you. Our listeners don't. But your face lit up when you said that you just loved what you did. So Cook County served you well, and you went back there because you missed the camaraderie. Was it a bunch of like-minded folks, people that all had that sort of passion?
I would say most of them were, especially in the Department of Medicine. A lot of the primary care specialties and most people who had the same sense of why they were doing it gravitated towards those specialties. So I was working with people who were like-minded. And it just made it was just a wonderful experience. And I'm still in touch with a lot of those physicians who were still focused on doing the right thing, on addressing health inequities, working with the underserved. People are still out there doing that. There's physicians that within PNHP that came from Cook County. That was where I first learned about single payer, was at Cook County Hospital. The roots are there, the sense of doing good.
Yeah, that mission, passion, purpose. And how much of an antidote to burnout do you think that is?
The burnout nowadays is something totally different than what I experienced as burnout. God, I'm on call again. That kind of burnout. What's happened now is that the whole privatization and the profit motive of the healthcare industry has changed the role of the physician tremendously. And it's difficult to have the same kind of passion in that system that I had in the system when I worked. And what I mean by that is that now doctors are overburdened with administrative responsibilities. Many are employees now. They're told what to do, which may not always be in the best interest of their patient. And before, everything I did, even if patients didn't agree with me, well, then you looked at plan B. Well, how can, we figure this out and I can still get you to where I think you need. So now it's more difficult to have patient relationships now than when I was, because you're limited in the time that you can spend with patients. You have to focus on only doing this and only doing that. And if you can't address all their medical problems, it's just an absurd way now that medical care is being driven by profit motive insurance companies and equity firms and hospitals, and that it's more difficult to provide the care that patients need.
I think it's a perfect distinction that you've made. And in a way, it makes me think about Frederick Hertzberg, who wrote an article a long time ago called One More Time, How Do You Motivate People? And he had hygiene factors and then motivators. And the hygiene factors were things that were table stakes. You had to get over that threshold before you could even get to the point of feeling the kind of passion that you lit up talking about. So the hygiene factors, I think of them as more basic human needs. We have to be out of a threat state and have a sense of clarity about what we're doing and autonomy in the work we're doing. It's critical to have a level of autonomy that is commensurate with the responsibility that is on our shoulders. And if we have huge responsibility and accountability for patient outcomes, and we don't have a commensurate level of authority or autonomy to achieve those outcomes, that is the recipe for burnout. And you can't get to passion and purpose and all those incredibly motivating factors if you don't have ability to function as a professional. So you made this great distinction, Susan. You had like-minded folks and you were all passionate about what you were doing, and there might have been some burnout, and it would have been related to exhaustion. And you made that distinction with what's going on now, where physicians actually are deprived of a sense of purpose and they're unable to fulfill their responsibilities to patients. Have I done an unfair kind of wrap up of that concept?
Not at all. And one of the things I want to add to that is that I was able to see my patients as people, as a person. They weren't a 62-year-old with diabetes and hypertension. They were Mr. Smith or Miss Jones. Mm-hmm. They were people. And they would come in, especially when I was in primary care and saw people over the years. They'd bring in pictures of who had a baby and who graduated, and they'd fuss about their spouse. They were people. And I wasn't just treating their blood pressure. There's many situations where I could walk in the exam room and tell when something wasn't right, because I had seen the patient so many times before, and they weren't just their blood pressure or what was their sugar. They were people. And that's what I really liked about it. They shared their lives with me. It's a relationship that's gotten lost. It's not respected anymore. The importance of a particular doctor with a particular patient isn't respected anymore. It's like, oh, well, Dr. Rogers isn't here. Well, just any all other internists will do. It's just like the people your friends. If they can't go to the movies, you don't just replace them with another person.
Here's another Heidi. You can.
Exactly. The importance of the relationship in medicine is being destroyed because physicians are looked at as replaceable now. You don't need a physician. You can get a PA, you can get a nurse practitioner, and they do have roles, but we're not all interchangeable. And no matter how good another doctor is, that's not your doctor. That makes it difficult when you get into situations that are difficult to navigate. When someone has cancer, when someone needs surgery. I mean, those are stressful situations, and it's much easier to get through those with somebody you trust, with somebody that you respect, with somebody that cares about you.
Right. You've covered so many different points here. I have about 3 different directions I would love to go based on what you just said. And the first one, I'm going to indulge my curiosity. Can you tell us a story of a patient you really connected with and it made a difference, or it's something that you still kind of reflect on?
Oh, yeah, there's several. I remember there was an older gentleman, and he was a Tuskegee Airman. He was old, and he had some medical issues, but they were well controlled, and he was very pleasant, and we would chat when he would come in to see me. And when I transitioned into becoming a hospitalist and working more with medical students, and I left the clinic, it was really sad. But he used to call me every Christmas just to wish me Merry Christmas. He would page me, we would chat, we'd catch up and stuff. And I knew he was in his 90s. And I was thinking, one day he's not going to call me.
Mm-hmm.
And one Christmas he didn't. It still makes me sad. Those are the relationships where they're more than their medical problems. They're real people. It must have been about 5 or 6 years before he passed.
Yeah.
And I would look forward to that call. And I remember that the year I didn't get the call.
Yeah, that is touching. And you talked about the loss of relationships, and I couldn't agree more. And can you drill into that a little bit more? What do you pin that on exactly? Like what logistically or politically, what is actually going on that physicians are unable to establish relationships with patients?
Part of the problem is that most physicians are employees. When I finished medical school, people ask, are you going to open your own office? I don't think anybody asks a medical student or someone finishing their training that now. They ask, what hospital are you going to work for? What group are you going to join? Most people don't go out on their own now. It's over 70% of physicians are now employees. So now physicians have to respond to a boss telling them how long they can have with each patient, even if you don't cover all the things you medically need to cover.
Right.
You're an employee, and this is what you have to do. And you have to do certain things or certain medical record things. You have to click certain boxes, and all of that has to do with coding and how they get reimbursed for that care. So there's other aspects of your role now that goes beyond what your interaction is just with a patient. And your job is dependent on those now. It's not about how well your patients do necessarily or how well they like you. It's how many patients have you seen? Did you do all of your administrative work? There's more time spent on administration now than physicians in any other country. Nobody spends the time that we do checking boxes and making sure that all of that is done so that the medical group can get reimbursed more. And the fact that we're not looked at as a key part of the delivery system because we can be replaced.
Physicians really have been treated as commodities. And as you said, they're interchangeable.
And even if you don't have difficult chronic medical problems, you still have a relationship with that physician. And you don't want to just end up having to see Dr. A because you're the doctor that you've been seeing before is no longer there because of whatever reason, or they've been told to go elsewhere because they're part of a group and that's what your employer told. I mean, we've lost our autonomy.
We have lost our autonomy. It is an autonomy deficit in a profession that requires autonomy like no other. And professions require autonomy, but what could require more autonomy than the precious relationship between a physician and patient?
Exactly. It's just, to me, frightening. I mean, now everything is decided not by what you need or what you should get, but it's decided by whether it can be paid for.
Right.
If you need certain medical care, that's decided on whether it gets paid for. It's not decided on what you need. It's not decided now on what your doctor thinks you need or should have. It's decided on whether it can get paid for. And that privatization and the for-profit nature of medicine is what's destroying our healthcare system. It isn't helping it. And if you look at, in other European countries, that many have universal coverage, many regulate costs, many provide care to everyone. Those relationships aren't as destroyed there as they are here.
No, it's more of a blend in the UK, but in other European countries, physicians are much more likely to be most of the leaders or exclusively the leaders of healthcare systems and hospitals.
But even our private insurance companies are moving into England. It's destroying the system there. And now it's difficult to know who owns what. There's all this vertical integration of corporations, and you have all these systems, and there's no connection between the systems anymore other than financially.
Right.
They're not geographically connected. Their medical staff is not connected. It's just financial connections.
Do you have any sense of what I call the business school mindset, or the mindset that seems to come out of our business schools when people matriculate there to get their MBAs? They are primarily the ones who are running our healthcare systems and hospitals now.
Yes, and those are also the people who can afford to pay for their care out of pocket. So they don't see the impact of what they do. And when you stay in the boardroom, you never see the patient bleeding in the ER.
Right. And they never have seen them.
It's a total disconnect.
Total disconnect between leadership and between what's going on, I guess, in the organization.
And it's not just leadership, it's the decision-making. Who decides how many nurses there should be? It should be someone who knows how healthcare is delivered, how you can function. You can't have one nurse taking care of 10 patients. I mean, you can't. But if you're driven by money, well, they just have to work a little harder. I mean, it's this whole disconnect and not understanding. There should be no role for them. I mean, it's just, it's the bully from the neighborhood doesn't belong in the playground, Yeah.
The business school mindset has taken over so many of our social systems and educational systems, political system. I mean, I think it's so relevant to what's going on politically. They call it rational egoism, the sense that anything you do should be motivated to serve yourself. That is the greed is good mindset. And they have totally swarmed through healthcare and turned physicians into commodities. We're not leading our own profession, but they've also taken over all kinds of business and they're doing enormous damage. It is like the schoolyard bully who's gotten so huge and we don't see him.
Yeah. And even public education for elementary and high schools.
Really?
Been taken. I mean, look at what happened with charter schools. They took the money from the government, had no accountability for what they do. And so they decimate the neighborhood schools. And knowing that neighborhood schools are funded by property taxes, of course, the communities with the least value in real estate suffer the most. Wealthy neighborhoods don't have charter schools.
Okay, say more about that, Susan. I don't understand. The charter schools don't exist in the wealthy neighborhoods, and they're being used to exploit the poorer neighborhoods, it sounds like.
Yeah, part of it is structural racism. Is how is public education funded? It's funded by property taxes. So if you have a community where the average house value is $500,000 versus a community where the average house value is $100,000, who's going to have the better funded schools?
So the public schools will be excellent in the rich neighborhoods, basically.
Yeah, because they're funded by those property taxes, the areas where they have shopping malls. When you have poor communities with poor schools, the only alternative is private schools, which often those parents cannot afford. So then they develop charter schools, which took money from the public school fund and gave it to these charter schools without any accountability for what they do. And what they do is they kick students out who aren't the highest performers so that their statistics look better. Oh, yeah, all our high school students went to college because the ones who couldn't do that were kicked out. It's the privatization of a public good. And again, that leads to more inequities. It changes what is public education for then. If you're not funding it so that children can learn, but you're using it as a way for other people to make money, it's just like all these funds that are for public goods are being diverted to MBAs and people who run schools for profit. And the charter schools don't pay as well, but they have students who may be more focused. So it's an easier job, maybe a better environment.
They're not supporting and serving the students who need more help.
Exactly. If this student is having more trouble, if they're misbehaving, you kick them out.
It sounds like the situation with rural hospitals that do not serve the profit interests of the big systems that buy them up and then shut them down.
Exactly. And that's part of what's wrong with the way we fund healthcare is that, if you have a poor payer mix in your hospital, if most of your patients are Medicaid or Medicare, they're not going to have, hospitals charge private insurance 2 and 3 times as much as what Medicare or Medicaid pay. So those hospitals have much more money. Plus, you walk into a large for-profit hospital in a large city, one of the first things you see is a wall of donors, millions of dollars. You won't see that in a rural community.
Right. On that note, it would be great to hear more about PNHP. I'd love to hear what you want us to know about the Physicians for a National Health Program organization. What should we know?
Okay. Physicians for a National Health Program is a nonprofit organization with a central office here in Chicago. And we have chapters in not every state, but in many states. And actually, some states have multiple chapters. We also have student chapters with medical students, pharmacy students, other healthcare students who are part of the student chapters. And so our mission is to advocate for single payer, which I described earlier, where the government is the payer and everybody has the same benefits. Everybody gets covered for the same thing. So that now healthcare is prioritized based on need versus prioritized based on how much you pay. And so right now we have a system whereas if you don't have money, you never get on the list. You're not prioritized. Right. And so single payer would eliminate that so that, and even the CEO of Mayo Clinic publicly said they would prioritize privately insured patients over Medicaid. I think it's illegal. It's immoral if it's not illegal. But what it's saying is that if you have a way to pay, you can access your care. And so this is what we are against, that prioritization of care based on money. And so what it would do, we would place services where they are needed. And so right now, if you look at community, where I work is the Illinois Medical District, and there was Cook County Hospital, which was a large hospital that did everything. Rush University Hospital did everything. The University of Illinois did everything. The large VA hospital there did everything, all within a 1 mile radius. However, you go 2 or 3 miles away and you're in a hospital desert. So resources aren't placed where they're needed. They're placed where they can generate more money for the hospital institution. And so that's why you end up with rural hospitals closing, and you get these mega areas with an abundance of resources. And so they compete with each other to do, rather than create resources and healthcare access to areas that need it. Even where Rush is, I'm on the faculty there, and they tore down some housing right across the street to build a cancer treatment center. There's already 3 cancer treatment centers there. Rush already had one in the older hospital. But this was a way they could make more money. And so a single payer system would eliminate that incentive. They could have built a mental health institution because clearly there is a lack of those resources, but there's no money in that. But if it's all paid the same by the government through a single payer system, it would provide the care that's needed. And so that has to change the priority of how you develop and build and encourage the growth of healthcare resources, and you put them in areas that need it. It's just like a fire station. You never pull up to a corner and find 4 fire stations on each corner.
Right.
You want them spread out so that each house has access to a fire engine to put out the fire if there's one there.
So you will find the Walgreens and the CVS pharmacy on facing corners, and for the same reasons. They're actively competing against each other, and it's about the profit.
And if you look at poor communities, they have half the pharmacies that wealthier communities have. And then when you make policies such as go to your local pharmacy for your COVID vaccine, who doesn't have a local pharmacy to go to? And so that structure just creates inequities and encourages those inequities to get worse. And that's why this privatization with DCEs that PNHP is against.
Talk about DCEs. What are those?
Direct contracting entities created by the Center for Medicare and Medicaid Innovation that was created under the Affordable Care Act. And the problem with them is that it was created without them having to have any oversight. Congress doesn't even know what all they do.
Wow.
And they get $1 billion a year. And so what they're doing is privatizing Medicare, in that they have these entities that are taking over. And that if you see a doctor, let's say you see me, and I'm employed by ABC Medical Group, and ABC Medical Group is now working with a direct contract entity. If you've seen me, you will now be part of that direct contract entity because you're aligned with me, even though you chose traditional Medicare. So they've taken your choice, aligned you with me, and their response to, if you don't want to be part of that direct contracting entity, that's the only way that you can see me. So if you don't want to be part of that, just find another doctor. You know, again, it's belittling the relationship, and finding another doctor is not easy.
Is that the same as Medicare Advantage?
No, it's similar to that. But Medicare Advantage, at least you had a choice about whether you wanted to be in that or not.
Right.
The direct contracting entity, you don't. But the direct contracting entities are similar to Medicare Advantage, but they're more predatory. They're more virulent. They're like on steroids because they have now involved private equity firms. They, as we know, have one mission.
Mm-hmm.
And how do you say that you will address inequities by providing care to those who haven't had services, who are in need, when you've got an investor who was giving you millions, if not billions of dollars? How are you going to pay that investor and provide care to a group that has high needs? It's impossible. I'm not an economist, but Eco 101, I know arithmetic. And so the whole concept This is what they did with Medicare Advantage. They just upcoded, they made people look sicker, so they got paid more for seeing each patient, even if they didn't provide more care. And it'll be the same way with these direct contract entities. And they just have to say, well, this patient lives in a neighborhood without a grocery store, so we need to have more money to take care of them.
And then it's a private equity company, so that profit goes off to the investors.
Exactly. I mean, how do you pay a CEO tens of millions of dollars a year when you have a traditional Medicare program that has a 2% overhead?
You don't.
Exactly.
Right. That wouldn't be happening.
They keep trying to dress it up and make it, sound like this will work. And I don't know what language they're speaking, but it does not make sense. It's like what Maya Angelou said, one of her quotes is, when a person presents the way they are, that's the way they are the first time.
When they say what they are, believe them.
Yes. The whole concept is based on perpetuating healthcare as a money-making venture. The costs are high because they're not regulated, because you can make more money if the prices can keep going up. So let's not regulate them, because then we'll limit the profits.
You got to hand it to the lobbying organizations. I mean, it's impressive what they've been able to pull off. There was original or traditional Medicare, and then
it still is.
Right. But that's all there was as far as Medicare originally. And then Medicare Advantage came along and offered that approach through insurance companies. And now it sounds like the attempt is, with what's remaining of traditional, probably 50% of the Medicare beneficiaries are still in traditional Medicare. Now this new onslaught of profiteering is focused on this remaining chunk of traditional Medicare. And you've had some success in battling this. Can you give us a thumbnail on that?
Yes, we started talking about this, and we gave talks, and we had a petition that we sent to many organizations. We had over 250 organizations signing our petition, saying they were against the privatization of Medicare with these DCEs. And we took the petitions and we went to DC with them. And we had a rally outside the HHS building, and we had already talked to Becerra's office, and we went over there with our petitions. And of course, they wouldn't take them. They didn't let us in. But we did leave it there. I don't know if he ever saw them or not. And then that afternoon after our rally, we had made appointments with several Congress people, and many of them had no idea about this program. It was built and created without oversight by Congress. And so many were quite appalled directly because of what P&HP did. They came back and they said, okay, we'll change a little bit. And so now they've done this thing that they call ACO REACH rather than DC. But it's essentially the same program. They still have these middlemen there siphoning off the funds. And there's no way that you can address the inequities in the system we have if you continue to siphon off funds.
Right. If we continue to support the middlemen.
Yes. It's sort of like if I said, you can go to the store, it's only 50 miles away, but you can save $5. So you come back and say, look, I saved $5. But wait, you had to spend how much time and gas money to go that 50 miles there and back? So you really didn't save any money, but they don't couch it like that. And then the amount of money they save is minimal, 0.1%, 2%. I mean, it's a minimal savings considering the billions of dollars that they're essentially stealing from the Medicare Trust Fund.
Yes. And it's coming out of a different pocket. It's coming out of your family's bank account if it's in your time and gas, and the money is going into those who are privatizing the healthcare system. Susan Rogers, I need to let you go. I
totally enjoyed this. But
yes, I have so many questions left. I'm going to just have to think, what am I going to do about that? Could you just give us some sense of what might surprise physicians if they embraced or learned more about PNHP?
I think if you learn more about PNHP, you will find that we are dedicated to a healthcare system where we see healthcare as a right, and it will take away the for-profit motive of delivering healthcare into a motive that reflects the reasons why we became physicians. Mm-hmm. We became physicians to take care of patients. I will admit, some people became physicians to make a lot of money, but that's not the majority of us.
No.
We became physicians to take care of patients. And we need to get back to that. And PNHP will help us get back to that with a Medicare for All system.
Thank you so much for spending time with me. And I wonder if you want to let us know where people can find out more about you and PNHP.
You can go to our website, pnhp.org, and there's a lot of information on there. There's also another website we have called protectmedicare.net.
Okay.
And that has a lot of information about the direct contracting entities, the new ACO REACH program. And on both of these sites, there's videos, there's slideshows, there's links to papers. So it's a wealth of information.
Excellent. Thank you so much for your time. It's been wonderful meeting you and having you on the podcast.
Well, thank you so much. I enjoyed it.
Great.
Thanks for listening to the License to Lead podcast. Be sure to visit licensed2leadpodcast.com to join the conversation, access the show notes, and sign up for our newsletter. Leave us a message with your provocative question or your thoughtful comments. You might inspire a future episode of the License to Lead podcast. Thanks so much, everyone.